Well, thank you to Ellie for inviting me here today to talk to you a bit about burns and dealing with the challenge of burns and the importance of aftercare. So the topics I want to cover today are just classification of burns, burn wound assessment, first aid, treatment of burns, scar management, and psychological issues. There's quite a lot that I want to get through, so it'll be a bit of a race to get through it all. But it's all very, very important. So classification of burns. So we don't tend to see burns like that often. Obviously, our bigger burns that end up in ITU, they do tend to be flame burns. But the majority of our burns are much smaller burns that can be actually treated in our outpatients department. So just going to go through a few types of burns that we see. So as I say, flash and explosion, not terribly common. Although last year, around fireworks night last year, we had 4, I have to say, they were men in their late teens, early 20s, and they all, totally different incidents, but they'd all been involved in very similar incidents. And that was that they were all walking along, minding their own business, not a care in the world, and a firework had shot out of somewhere, don't know where from, hit them in the hand. And they all had very nasty burns. They all had to be grafted to get these healed. And it turned out that on YouTube, there was a challenge to see who could hold the rocket for longest. So YouTube has an awful lot to answer for. Unfortunately, we find with a lot of the teenagers that they do go onto YouTube and look at these things. There was an 11-year-old lad in the Midlands last year who'd looked on YouTube, and there was a good challenge: set yourself alight, but make sure you're standing near some water so you can put yourself out. So he was near a river or something, but he jumped in, but unfortunately he sustained really nasty burns. So that's the sort of things we tend to see. Scalds, these are our bread and butter of burns, particularly with the young children. So with the toddling age, they can just reach that little bit higher, pulling the hot drinks down over them, and parents don't realise that they can now reach that cupboard top that they couldn't reach before. And then as we get older, the older generation, again, scalds are more common as well. Electrical burns. You've got your high voltage electricity and your low voltage electricity. With electrical burns, you need to be aware of what's happening internally. It may not look, you may just have a few little entry sites that are quite deep, maybe to your hand, and an exit point to your foot. But you need to be aware where that electricity has travelled. So it's travelled through your heart. So patients do need to have ECG and make sure that they're all right cardiac-wise. And also be aware that the bone heats up as well. So you can end up cooking from the inside. Chemical burns, again, lots of different ways you can get burnt with chemicals. We had a couple of little girls last year one had gone round to her friends for a play date. They were playing in the bathroom, playing at beauty salons. The little girl got out the spray from under the sink and sprayed it over her friend's face, and it was actually a chemical cleaning solution. And the poor child got really horrendous burns from that. The Hydrofluoric acid is a particularly nasty chemical. People who use it tend to be used for tombstone cleaning, glass etching. Apparently it's used for cleaning alloy wheels. People who work with it tend to know how dangerous it is, but a 2% hydrofluoric acid burn can actually be fatal. And the antidote for that is calcium gluconate gel, which people who work with it tend to have it on site. And I've only ever seen it that they've got a little hole in their gloves and it's seeped in, and they get very nasty, incredibly painful burns to their fingers. Contact burns. Again, the little ones, toddlers pulling themselves up on radiators, touching irons that have been put somewhere to cool down and they can reach. And again with the elderly, collapsing, and they collapse against a radiator or something hot and they get wedged and they can't get up. Radiation, so good old sunburn, which unfortunately we still do see quite a lot of, and other ways there. And frostbite. So we don't see that much frostbite in this country, but we do get people who've been exploring in very cold places and come back and they have sustained frostbite. So we do see that sometimes. So burns frequently are caused by carelessness, inattention or intoxication. The majority do occur in the home. It is a method of assault in adults. I'm sure you've all heard of the famous people who've had acid thrown at them, like Katie Piper. Unfortunately, that is an increasing thing. We are seeing more and more people who are being assaulted with acid. And also in prisons, if you ever unfortunately end up in a prison, watch out, because it's quite common to have boiling water thrown over you with sugar in it, because they know that with sugar in it, the water's going to stick even more and you're going to get a deeper burn. And also a method of child abuse. So we are very aware when children come in with burns, we do look closely and make sure that the story tallies and the burn fits with a description of how it happened. Now, healing is dependent on the quality of the initial management of the wound, and we can't reiterate this enough. First aid is so, so important, and I've just got a few slides now just to demonstrate that to you. So first aid for any burn is cool running water for 20 minutes. Now this is beneficial up to 3 hours post-injury. So if you're seeing somebody and they haven't done any first aid, but it's within that 3-hour period, it's still really beneficial to get that cool running water on it. Obviously removing any jewellery and removing any clothing. If the clothing is stuck and you can't lift it off, then just leave it in place. But if it's loose, then remove the clothing. Things not to use. We get all sorts of things that people put on burns. And basically anything that's in the store cupboard, someone will put on a burn. So eggs, flour, turmeric is quite cultural. A lot of places use that. Ice or iced water. Again, that can make the burn deeper, so we don't recommend that. Tomato ketchup's fairly common. We have had a couple of parents, they were from Eastern Europe, and they actually urinated over their children, which we were quite horrified about. Sudocrem, it says on the packet for burns, but it's a nightmare. Anything like that is going to hold the heat in and potentially make that burn deeper. So just a diagram of the layers of the skin here. So obviously the deeper the layers of the skin are damaged, the deeper the burn's going to be, the longer it's going to take to heal. And this is the Jackson's burn model. And just to, again, this is just to show you how important the first aid is. So with the Jackson's burn model, the orange area in the middle there is the zone of coagulation. That's where the damage is done. There's not a lot you can do about that. But the area around it, the red area, the zone of stasis, that's amenable to good first aid and to good dressing technique in the initial stages. And we can just liken that to eggs, just to make it a little bit clearer. If you imagine that the yolk of the egg is the zone of coagulation, that's the central area, that's where the damage is done, you can't do anything about that. The white of the egg is the zone of stasis. So if you're cooking that egg, at any point you can remove it from the heat and you can stop it from cooking anymore. So it's very similar with burns. We must remember that burns are dynamic. So what you're seeing in the initial phases may not be what you're seeing in the next 48 hours. They do develop over the first 48 hours. This is a very extreme case, but you can see in the day 1, it looks like a fairly partial thickness burn. Day 2, it's looking a little bit deeper. But by day 5, you've got a full thickness burn there. I say that's very extreme, but it does happen. And I've just got a couple of case studies now just to show you, again, just to reiterate the importance of good first aid. So this was a very typical child, pull-down injury, cup of black coffee. No first aid was given. Mum didn't know what to do, didn't have any first aid. And when they first presented, you can see at the top of the arm it's a little bit whiter, the area there is a bit deeper than the top of the chest. 3 days post-injury, you can see those areas are much, much deeper now, much deeper burns he's got there. Now we aim to get the burns healed within 2 to 3 weeks. If burns heal within that time frame, you'd be unlucky to have any permanent mark or any scarring. So what we do is we do dressings, or generally what we do is do the dressings for 2 weeks. If at 2 weeks they're not healed, then we get the consultants to have a look and they decide whether they feel they need to do surgery or not. So this little one had to have surgery because you can see the areas still at the top of his arm and top of his chest are still quite raw. So 28 days post injury, he's had skin grafts, they're all healing nicely. 2 months post injury, it's all healed, but he's got scarring there. 4 months post injury, 14 months, the hyperpigmentation is fading, but he's still got scarring. And he's going to be left with that for the rest of his life. And at 6 years, so the hyperpigmentation's faded, but you can see he's still got scarring. The next little one was very similar injury, so scored from a hot black tea. But Mum knew exactly what to do. She got him under cold water for 20 minutes, wrapped him in longitudinal strips of cling film and got him to hospital. So these were the photos from the referring hospital. 3 days post-injury. Now his face looks absolutely awful. Faces always look much, much worse before they look better, but they actually heal really well because you've got such a good blood supply. 8 days post-injury, areas are beginning to heal up. 12 days post-injury, more healing's taken place. And at his final visit, which would have been between that 2 to 3 week period, everything's healed up. He's just left with a little mark under his chin. So he didn't require any further follow-up. 1 year on, he's having fun. And again, he just left with that small area under his chin. So that just demonstrates how important the first aid is. I think people think it's like putting an elastoplast on a little cut, but it's not. It really is part of of getting the burn healed right from the start. So for the burn wound assessment, we need to assess the size of the burn and also assess the depth of the burn. So to assess the size of the burn, we use the Lund-Browder charts at Chelsea and Westminster. There are other ways of people of assessing. There's the rule of nines, but we also use the palm of the hand. So the palm of the patient's hand with the fingers together, that's 1%. So remember, it's the patient's hand, but that's quite a good way of just quickly being able to tot up how big the burn is. But we ignore simple erythema. So if it's just redness of the skin and there's no blistering, no broken areas, that's not included in the size of the burn. So for depth assessment, so this is simple erythema. So as I say, this would be like a quick flash of flame or a sunburn. Skin's going to be very, very red. I'm sure if any of you had sunburn, you'll know it's incredibly painful, blanching briskly. But something like this will fade away within 7 to 10 days, just with using a simple moisturiser. I'm not sure if the guy on the left did this intentionally, but as I say, people do weird things. We had a lady last year who actually laid out in the sun with bits of cord over her in a sort of a nice designer checkered effect and got thoroughly burnt and was very proud of herself. But we thought it was going to become a trend, but fortunately we didn't see anyone else who did that, but they do weird things. And then we're going down to the epidermis now. So you're now going to have, for your partial thickness burns, you're now going to have skin loss or big blisters in situ. The wound bed's going to be very pink still incredibly painful, blanching briskly, very, very wet, lots of exudate coming from the wound. But something like this will heal within 10 days to 2 weeks, just with a simple non-adherent dressing. There's nothing that you particularly need to put on a burn like this to get it to heal. We don't, with our criteria, we say if it's a partial thickness burn, less than 3% in an adult, less than 1% in a child, then potentially that can be treated locally. There are specific areas that we would say we would need to see them, so that's all in our referral criteria. So there are areas we would need to see, but generally that can be treated locally. Then we're going down deeper through the dermis now. We've got your deep dermal burns. The wound bed's going to be much, much redder now, sort of cherry red. It's going to be sluggish or non-blanching, potentially not as painful as a partial thickness burn because the nerve endings have been damaged. The hair follicles, the hairs will pull out easily because the hair follicles are damaged. And something of this depth is going to struggle to heal within that 2 to 3 week period. So we would say any burn that's this depth or deeper, we would want referred to the burns unit. And then we go to our full thickness burns. So down through all the layers of the skin now, down to underlying structures. You typically get the brown leathery appearance that you can see in the bottom picture on the left there, or the very white dense areas. Now these tend to be pain-free because all the nerve endings are damaged. So quite typically we get patients coming in, they haven't bothered to go and seek any medical help because they say, oh, well, it doesn't hurt, it's fine. And then the alarm bells are ringing because potentially that's going to be a full thickness burn. Something like this will definitely need surgery to get it healed, so definitely would need to be referred to us. We do tend to find that in the winter you get people who fall asleep with hot water bottles against their legs. They get very small but full thickness burns, but I think because they're small people think, oh well, we'll treat them, and then 8 weeks down the line we're getting the phone call saying, can you have a look at this because it's not healing. So we'd far rather see them straight off. So treatment for the burns. So for conservative treatment, as I say, the majority of our burns are just treated conservatively with dressings. So an ideal burn wound dressing, you can read that. So you want a nice moist environment and something that's not going to be painful, a non-adherent dressing, something that's going to come off the wound easily and not get adherent to the wound. So as I say, with the partial thickness burns, you don't necessarily need to add anything to your non-adherent dressing. In the burns unit, we tend to, I think as nurses, we always like to feel like we're doing something, don't we? So we do tend to use Furacin, which is an antimicrobial ointment, or honey we use quite a lot as well. But it would heal just with a simple non-adherent dressing. There are just a few non-adherent dressings there. And the secondary dressing, you do need to pad the wounds really, really well. You get lots and lots of exudate coming from the wounds. We like to leave the dressings on for a few days. We don't like to be changing burns dressings every day. They do need to be padded well. And then be inventive with your dressings. We have some lovely comedy dressings go out of the clinics. Hands especially, we find if people have burnt their hands and they've got circumferential burns around their fingers and around the hands, then actually for the first 48 hours it's much better just to put them in non-adherent dressing, obviously wrapping the fingers separately, and then just putting lots of padding on, and they go out with these huge boxing glove dressings, so it's quite comical. And children as well, if a child, it doesn't matter where they've got a burn, if it's a little burn on the back of a finger, never just put it into a finger dressing because they'll have that dressing off as soon as they've got out of the door. You need to again put them in a big boxing glove dressing because that's the best way just to keep it all in place. So patient advice. So obviously you're going to alert them to the signs and symptoms of infection. Good wound care, keeping the dressings on, keeping them dry. It's amazing how many people will either put a plastic bag over the dressings and then get in the shower, and then water can actually get in without them realising it, and obviously there's more risk of infection. I saw a patient the other day who said that his dressings had got a little bit soiled, so he'd got in the bath with both his dressings on his feet, and this was on the Friday. I didn't see him till Tuesday, and he said, I think they're okay though. They were, but I thought he's had those soggy dressings on so for a good few days. So they do need to be told not to get into the bath or shower with the dressings on. Good nutrition, good high protein diet is going to help get that burn healed. Keeping limbs elevated as much as possible as well. And with children, there's a low threshold because of toxic shock syndrome. You could have a child could have a very small partial thickness burn. It may be a small partial thickness burn, less than 1% to the chest, so it's being treated locally. We don't even need to see it in the burns unit. But there's a risk that they may get toxic shock syndrome. It tends to happen between days 2 to 5, and it tends to be more prevalent in the age group 2 to 5-year-olds. So we always advise the parents that if the child becomes unwell, get diarrhea, vomiting, a rash anywhere on their body, high temperature, then they must get in contact with us or with their local hospital as soon as possible. Because if it is toxic shock syndrome, they can go downhill very, very fast. The burn itself may look absolutely fine. You might take the dressing off and it will look absolutely fine. And no, it doesn't look infected at all, but it is something to be aware of. And then a surgical approach. So the surgical treatments we use, debridement, skin grafts, split skin grafts, and full thickness grafts, direct closures, they do flaps as well, and amputation. So aftercare of the burns. Now we're very, very fortunate on the burns unit because we actually have therapists who run scar management clinics. So they literally run a clinic alongside our dressing clinic. So they will see patients whenever the nurses ask them to see them, really, and we'll follow them up for aftercare. So as I said, if their burns are healed between 2 to 3 weeks, then they're unlikely to get any permanent mark. But anything that's taken over that, then it's potentially needs to be seen. So all high-risk patients, people with darker skin and people with very fair skin tend to have a tendency to be more likely to scar as well. So that all needs to be taken into account. If there's a history of people getting keloid scarring, then obviously there's more chance they're going to get scars as well. So I'd say any burns that take over 3 weeks to heal would need to be referred to the therapist, because they're at a greater risk of getting hypertrophic scarring. Any burns that have been grafted or had any surgical procedure, because obviously they're going to get scarring from that. And all high-risk areas. So we did find that children, if they had burns to the palms of their hands, even if they're healed within 10 days, sometimes they can. We found that they were getting contractures. So we now refer our children with burns to the hands. After a week, we'd refer them to the therapist just to make sure that it's all going to be okay. Anterior necks as well, and axillas are particularly problem areas. You can see the axilla there. You can see that's quite tight with the scarring, and at the back. And that's a quite badly contracted hand. So the long-term impairment and disability the scars can cause, they can be quite uncomfortable. They can get very itchy. And painful. Quite a lot of patients will complain about the pain from the scars, and hypersensitivity as well. And also there's psychological distress. The cosmetic appearance can worry people too of the scarring, and limited range of movement and impaired function. That's just the front of the neck there, you can see. So the treatment that the therapist would use for scarring, all patients, once they're healed, whether they're going to be scarred or we think they're going to be scarred or not, are advised to moisturise at least 4 times a day, just with a simple moisturiser again. Things like bio oil and things like that, there's no actual evidence that that does any good, and in fact oils are more likely to make the scarring or the area blister, and then it's going to lead to scarring. So just a simple moisturiser, and they need to be moisturising at least 4 times a day. And then we use silicone as well, either silicone gels or silicone sheets, and pressure garments. So we have the therapists on site will actually make the pressure garments to fit on site, so they're made to measure garments. Okay, so I'll move on to psychological and social factors. And how they have an important influence on the entire course of a burn injury, on treatment and the recovery process. So again, on the burns unit, we're very, very fortunate we have a psychologist who's on site as well. So common assumptions. So size matters. So the bigger the scar is, the worse it's going to be. If it's on the face, it's going to be much worse than if you've got a scar on your stomach, for instance. As it gets better, and as the patient looks better, they're going to be feeling better. And people want you to tell them if they're looking better. And it's okay to ask people how they got that scar. I don't know what you think about all of that. But in fact, there's no direct relationship between size and distress, or between where the site is either. We have one of the psychologists always tells the story of a young lady who had a small, about 50p size burn to her abdomen, which left her with scarring. She was totally traumatised by this, couldn't bear to go out, was really badly affected. We had another a man who'd been involved in a fire, had terrible burns to his face and his torso and his arms. He ended up with a prosthetic nose because his face was so badly burnt. And within a year, he was back at work. He actually threw away his prosthetic nose because he said it was too much hassle. He'd rather just get on with it. So there really is no relationship between how it looks. It's how the patient feels. And it's also not, as they're looking better, it doesn't necessarily mean to say that they're feeling better. Now, I know I'm at fault for doing it myself. We get patients come back onto the ward and it's a few months down the line and you say, oh, hi, great, gosh, you look fantastic. Well, actually, that's a totally wrong thing to say. You shouldn't be saying that because they may be feeling really awful, and you saying that is just going to make things worse. And also, people don't necessarily want to relive the story and tell the story again, because that's just going to bring it all back and cause more distress. And then the last thing, so will I have a scar? Has anyone had anyone ask them about scarring, or not really come across that? In the burns world, that's the first thing patients will say. They'll go into A&E and the first thing they'll ask is, am I going to have a scar? So we need to be really careful how we answer this. We shouldn't be giving a definite opinion because we don't really know. We could look at a burn straight away, but as I say, they can develop over the first 48 hours. For any reason, if they got an infection, that's going to make the burn deeper. So they could potentially end up, if it takes over the 2 to 3 weeks to heal, having a scar. So we don't know what the answer to that is. So we don't want to give them false hope. We don't want to ignore the question either. We don't want to give them too much information. So what we need to say is that change is inevitable. It may look worse before it gets better. Scarring depends on many factors. And we don't know, we don't have a crystal ball, so we don't know how long this is going to take to heal, whether it's going to have a scar or not. But the job right now is to focus on what they're doing, and what they're doing is the right thing. They're being treated in the right place and getting the right treatment. Thank you.